Thank you to Mr. Turzi for invitation, and good afternoon for the others. HA, PRP, combined PRP-HA in knee osteoarthritis. The disease is characterized by degeneration of cartilage joint and subchondral bone, adaptive change in the synovial ligaments and tendons. Knee osteoarthritis is a heterogeneous disease associated with comorbidities which complicates the standardization of clinical studies. The current treatments for OA are palliative and symptomatic rather than influencing the biochemical environment of the joint. We are entering into an era of biology treatment. Viscosupplementation, HA, platelet-rich plasma, PRP, Visco PRP, all in one. Hyaluronic acid, from Greek, hyalos, which means glassy, and uronic is a glycosaminoglycan distributed in synovial fluid and component of the extracellular matrix of cartilage. Its use as viscosupplement in knee osteoarthritis starts at the end of the 20th century. Viscosupplementation is a procedure that involves injecting a jet-like substance into the knee to supplement the natural lubricant in the joint. Hyaluronic acid helps protect the joint by increasing the viscosity of synovial fluid. The use of HA is widely documented in the EBM literature in osteoarthritis called dry. Apart from the use of 5 monthly injections with historical HA Hyalgon, there is a consensus of viscosupplementation protocol of 3 weekly injections per year, cyclic repeat treatment. The opportunity of one-shot treatment came later. HA class effect. Different HA showed no superiority, effectiveness, and safety in terms of volume, concentration, molecular weight, linear or cross-link configuration, rate of administration, or viscoelasticity. HA as an alternative to NSAIDs. Ishijima and Cole compared in a recent non-inferiority randomized study intra-articular HA injection versus oral NSAID drugs for the treatment of knee osteoarthritis. No statistical difference in efficacy at 3 months in 2 groups. Stop frequency of treatment, HA lower than NSAIDs. Banu and Cole in meta-analysis showed no difference in efficacy between HA and oral NSAIDs at 4 and 12 weeks. Pain at the injection site was the most frequently reported event for HA. Gastrointestinal adverse effects were most frequent for NSAIDs. HA chondromalator effect. HA decreased cytokine in vitro activity of interleukin-1 in synovial membrane. HA decreased radiologic progression of joint space narrowing. HA decreased CTH2, an urinary biomarker of collagen degradation. HA reduced the loss of cartilage volume, medial and lateral compartment MRI. HA decreased the progression of arthroscopic cartilage damage score. HA reduced need for knee replacement with increased survival curve Kaplan-Meier. HA belongs to the therapeutic strategy for patients with knee osteoarthritis. Recent work by Miller and Block confirms the efficacy and safety of HA approved by the FDA. HA delays the use of prosthetic surgery and reduces the medical and economic costs. 2013 AAOS guidelines do not recommend the use of viscosupplementation. Inconclusive in 28. It is not possible to underestimate the major conflict of interest of American orthopedics. American orthopedics operate more often and earlier in knee osteoarthritis than in France. Since they have opportunities to practice transplant of cartilage in the context of surgical procedure, they reduce their use of hyaluronic acid injection. Methodological errors and inconsistency of some results of the ORC 2014 recommendation promote the controversy. It is the same for the use of the results of the Rouge meta-analysis. A careful reading of this meta-analysis would have revealed that tolerance was considered on 8 of the 71 studies selected, posing at least a methodological problem. HA controls pain and inflammation. HA helps restore joint function. HA prevents degeneration of articular cartilage. PRP. In the 21st century, autologous PRP has emerged as a treatment option for tendinopathy and chronic wounds. In addition to release of growth factors, PRP also promotes concentrated anti-inflammatory signals, including interleukin-1 receptor antagonist, which has been a focus of emerging treatments for osteoarthritis. PRP is an autologous blood fraction recovered after centrifugation in the supernatant plasma. It was demonstrated that a single centrifugation step is sufficient to obtain fraction rich in platelets. PRP is not a labeled blood product. PRP is not considered a performance-enhancing drug by law. A blood sample prior to the treatment by PRP is highly recommended, comprising HB more than 11, PLT more than 1050, VS less than 10, CRP less than 5. Platelets can be activated by artificial exogenous factors or endogenous factors after articular infiltration. In this slide, you can see platelets anatomy during PRP activation. Platelet concentration is approximately 1.5 to 2.5 times that contained in the native blood to achieve in vitro positive effects on osteoblasts and fibroblasts. A concentration of platelets 3 to 5 times that contained in the native blood reduce the effects of growth factor. Platelet secretum comprise over 200 organic products, including growth factors, anti-inflammatory cytokines. PRP stimulates cartilage matrix synthesis. PRP suppresses anti-inflammatory response. At present, PRP is highly variable across the different systems on the market. The ideal composition of PRP should contain a minimal amount of red, white cells, and not excessive platelet concentration. On this slide, you can see an optimal example of PRP. The protocol for sampling, extraction, and injection must follow the most stringent aseptic condition. The use of anti-inflammatory drugs and NSAIDs is not recommended during treatment with PRP, 10 days before and 21 days after. The injection of local anesthetic at the site of treatment is not conducive to tissue regeneration. The great variability in the composition of PRP, as well as the individual variability in serum platelet and the lack of standardization of PRP in clinical study make it difficult to compare. On this slide, you can find 9 positive randomized studies with a high level of scientific evidence in osteoarthritis. In all these studies, PRP is better than HA and HA better than PBO. Use of PRP therapy is not a validated option for knee osteoarthritis treatment. All data in the literature agrees on the lack of side effects, with the exception of temporary aseptic painful knee swelling. Visco PRP, PRP in addition with HA in osteoarthritis. HA boosts the effect of PRP. PRP promotes suppression of endogenous HA. CellularMatrix is a class 3 innovative medical device combines autologous PRP 2 ml by small sample of blood 4 ml, non-cross-linked HA 1.5 million Dalton 2 ml fermented concentration 20 mg per milliliter dispatched in the BCT tube. On this slide, the first step with sample, blood, and centrifugation. CellularMatrix uses gel technology for cell separation. 5-minute centrifugation at 3,400 RPM. High platelet recovery, 60–70%. Partial recovery of white blood cells, 15%. Selective depletion of granulocyte, 90%. No red blood contamination, 0.5%. CellularMatrix is the first model of bioengineering technique. RPRP meets with HA at 50% ratio. Platelet suspension in three-dimensional scaffold. Concentration near physiological blood volume with PLT integrity and functionality to release a cocktail of growth factor and anti-inflammatory cytokines. Top down in this slide, you can see HA, PRP, gel separator, red cells, excuse me. You see the technical of pumping aspiration for mixed HA with PRP and before injection. On this slide, it's a protocol VRP. And step-by-step collecting, centrifugation, resuspension with controlled movement and pumping aspiration. VPRP, there is no standardization of protocol Visco PRP. We can propose 3 injections spaced 1 week, 1 time per month, or 3 times per semester. It's possible to make a one-shot injection given early analgesic and anti-inflammatory effect. CellularMatrix is a method effective, safe, simple, fast, low cost. In conclusion, HA, despite recent controversy, remains an essential treatment of conservative medical management for knee osteoarthritis. PRP, despite the heterogeneity of products and protocols, is a safe and effective treatment option in knee osteoarthritis. VPRP, all-in-one PRP combined with HA, is the scientific evidence of its additive synergy of action. This technique is simple, fast, efficient, and secure. The future is moving towards the preventive biomedicine and earlier use of this analgesic and regenerative combination. However, further randomized studies are needed against PBO and especially with structural study of articular cartilage by MRI. Thank you for your attention.